First of all, welcome for the Utah Opioid Task Force Lunch and Learn. And lunch is over there. Make sure you get some. I'd like to give a thanks to the League of Cities and Towns and to the Utah Association of Counties for their sponsorship of this event. And I'm going to turn time over to Attorney General Sean Reyes, who will talk a little bit about our situation here in Utah, and we'll move on with the program from there.
All right, thanks, Scott. If you're having a hard time finding a seat, come on in, ladies and gentlemen. First of all, I want to thank our partners, I should say, that Scott will introduce, the League, and also UAC. The League provided our lunch. They've helped us organize the event, and they saw the vision, and UAC also, with their support, has many of their members on the task force. So if we did this already, I apologize, but could you just help me acknowledge the League and Cameron and all our partners there. Thank you. Look, we knew this was a little bit of a risk trying to do this during the middle of the session. Our hope was that we could showcase to a few legislators at least, and to other leaders of the communities throughout Utah, just a little taste of a road show that we're trying to create together with our partners to take from region to region throughout the state over the next couple of months, at least throughout the next year. So the purpose, again, of this event is to provide a demonstration of the types of community-based information and education seminars that our task force intends to develop and deliver throughout the rest of 2020. Just so you know, we have a tentative schematic creating 4 or 5 regions to cover the entire state, and we'll tailor information and content to meet local needs and priorities, assemble the teams to support those regional events, involve regional players and participants in those. We're hopeful that our friends in the legislature will assist us with these, help us get the word out, and that each of you, using your sphere of influence in your positions, will help us bring people to these events. The objective, of course, is to get this initiative off of the, as we say, the sketching pad onto the launching pad. And so, again, we're going to give you sort of short TED Talk-like bursts of information today, with the idea that if it's of interest to you, you're welcome to reach out and contact these partners. All of them are active and important members of our State Opioid Task Force, from our friends and members of the Health Department who are going to present today a exciting and game-changing opioid dashboard that gives critical information. We've got friends from Utah Naloxone who are here, Jen Plum and her team. From Banjo, we have Chief Tom Ross, who is pioneering a very exciting program that has potential to be used in every county and every city throughout the state of Utah and even nationally. And we have USARA, Mary Jo McMillan and her team. I will let Scott introduce them more formally as their presentations come up. But again, especially with the task force, the opioid task force, and I want to give credit to Brian Besser, who was the co-founder of the task force and is not here now in DC, running many programs for the DEA. The task force idea was to bring people together who want to try to solve this opioid epidemic, one of the greatest public health crises that we've ever faced as a nation, perhaps the greatest. People who have solutions themselves or want to find solutions, create an environment where they can all come and decide which solutions meet their needs, what things they're excited about, and then work from there. And it's worked well. We've convened a community of leaders in their spheres, and we come together. And we wanted to make sure that people all throughout Utah had access to these exciting programs, that the that the task force and our other partners like U-Co-op are finding and incubating and helping to support. And so this is our way, hopefully, of taking these programs and instead of waiting for you to hear about them or coming to the Capitol, taking them out to the communities, showcasing them and saying, if your community, if your county, if your city could use this, or you think you could use this, let us help you figure out how to implement it. Let us help you figure out how to get the funding. Let us help you figure out how to stand it up, tailored to the needs of your particular community. So I'm not saying it particularly eloquently, but that's the vision of what this initiative is for 2020. So again, we thank you who are here. Encourage you to go back and use the League's vast network, use UAC's incredible contacts to make people aware that there are solutions and that Utah is helping to lead the fight nationally on this horrible opioid epidemic. With that, I want to turn the time back over to our Scott. Should I introduce Chief, or is it coming back to Cameron and Brandy? You want to say something though, Cameron? And Brandy, is it? Brandy Joe? Right. Come on up.
Greetings, everyone. I'm Cameron Dill, the director of the Utah League of Cities and Towns. We represent all 249 cities and towns in the state. It's our honor to be part of this event and to sponsor the lunch today, and more importantly, be part of this visioning effort so that we can take it off the sketch pad, put it on the launch pad, and make a difference in people's lives in our communities around the state. Brandy?
Yeah, thank you, Cameron. My name is Brandy Grace. I'm the CEO with the Association of Counties, and I just want to say I'm thrilled to have the opportunity to be a part of this event, but more importantly, the work that the Attorney General, Sean Reyes, has been doing with this task force. For me, this is personal. And my family and I struggled with a family member who was addicted for a long time, and we didn't talk about it, though. Early on, it was something that I felt like was an embarrassment, something that we should be ashamed of. I was in public office and didn't want to talk about it, wanted to pretend it didn't exist. And we were in a rural community at the time, and I'm well aware that the resources were just not there to help us through that. Our circumstances have changed, but I do know the effects that this has, not just on the addict, but the families that also suffer with the challenges that come with addiction. So I applaud the efforts that are being done there, and I'm thrilled to be able to be a part of this and the good work that so many of you are doing. So thank you.
Yep, thanks.
Thank you both. Thanks, Cameron. Thanks, Brandy. So again, even though the legislators may not be here physically right now, oh yes, there we are. Thank you. Not all of our legislators, and we surely appreciate those who are able to make it. We're recording this so that your colleagues can watch afterwards, because I think you're going to be thrilled to find 5 different approaches and solutions. As Agent Besser used to say, it's a variegated issue, multiple layers of how we got into this problem in the first place. I call it a Gordian knot because there's so many different strands, and if you try to undo one, sometimes it complicates the others. Everything from manufacturers and distributors that we're potentially suing right now, to prescribers, patients, pharmacies to fill, insurers to cover recovery and treatment, and the treatment and recovery community, emergency services to keep them alive, law enforcement, and all of these we have to educate, we have to raise money. One of the people who has led this fight, and I'm proud to introduce right now, the former head of the Utah Association of Chiefs of Police, and the chief up in Bountiful, really saw the dysfunction of law enforcement trying to solve this really complicated problem on our own. And historically, a lot of the solution was we lock people up when they have, and the chief was one of the first great leaders that we had to say, you know what, I'm going to put my credibility and my reputation on with a law enforcement community that's resistant to change, and say we have to do things differently. And he's been fighting for this program that you're going to hear him talk about for the last couple of years. And now he has a pilot program up, and if it works well there, he'll be the template, I believe, for America to be able to adopt. And after the chief, I'll let Scott Reed, the head of our opioid task force, Sierra Gregovich, who also helps lead that task force, introduce the subsequent presenters. But please, when don't just be thrilled. Follow up with each of the presenters. Make referrals to folks in your areas, your districts, your constituents that you know can get things done, and then help us as we go out to the communities and put this roadshow on and showcase not just these 5, but maybe 5 more. We take 10 solutions. Help us get people in your communities. Like Brandy was talking about, we know that more Americans are dying of this each year than breast cancer and automobile accidents, all threats that we should pay a lot of attention to. More Americans dying in one single year than all of the Americans that we lost during the entire Vietnam conflict. The scale of this is unprecedented. And the last thing I'll say is, I know all of us are concerned about coronavirus. I've heard about 10 cancellations of conferences today, and I think we should be concerned about coronavirus, but we have an even more clear and present threat and danger that has been taking lives of Americans at a much higher rate than the coronavirus, I believe, ever will, and that is the opioid epidemic. So thank you for your attention. Chief Tom Ross is our first presenter, and Chief, would love to have you come and explain what the program is. So the mic is now yours, my friend.
Thank you.
Love you, brother.
Thanks. Well, thank you for allowing me to be here. General Reyes and your office, you've been great to collaborate with and work on this project. As was mentioned, this pilot program started about 2.5 years ago in conversation. I'll give a little bit of background in just a few minutes. But there are many hands that have helped with this. I think I get a lot of the credit, but I know that the work is being done by many, many others, and we have a great collaboration. But I also don't want to pass over in recognizing Representative Elison, especially Representative Hutchings. They've spent a lot of time talking with me and others in our group, building support, running legislation that's beneficial to this program. The governor and his office have been behind this and supportive. DPS, our local legislators, I know I saw Representative Ward just pop in, he's right here. They've been great supporters of this. All of our local elected officials, law enforcement, judges, prosecutors, we've met with everybody over a 2-year period of time. And I can say one thing for sure. This is probably the most collaborated effort in a program that I've ever been involved in 32 years. And I think because of that, we're getting a good starting point. So I'm going to walk a little bit. I don't like to just stand behind, but if you can't hear me, I'll try to talk loud. But I guess the first question that would probably come up is, why me? Why am I standing here talking about this? And I've been fortunate to have a very unique education over the past 5 years. As was mentioned by General Reyes, I served as president of the Chiefs of Police Association. So I sat in on hundreds of conversations regarding criminal justice reform, mental health, addiction, all these issues and problems, community relationships, police relationships with their communities. And I had the benefit of sitting on multiple organizations. So I'm part of the task force, as mentioned, and I also serve on USAID Plus. I serve on UCOOP. I'm currently the chair of Davis Behavioral Health. And so I've had a lot of information provided to me as a law enforcement executive that I would not have been privy to in any other arena. And here's what was interesting to me as I sat and listened to very smart people talk about issues and concerns that law enforcement probably resisted a lot of. Some out of just fear and concern that we might be doing damage, more damage than good. Others because it's not easy to move us sometimes. But I will say that what became clear to me is that law enforcement unintentionally was put in a position to fail for all the right reasons. And look at it from this perspective. If you are a victim of crime in Bountiful, and you're upset that the individual that has victimized you, you're aware that they've been arrested before, the police are here again, they're angry that we have not protected them. And so we're hearing from them, why aren't you doing better? On the flip side of that, if you are responding on a crisis call involving mental health, drug addiction, they don't want to see us. The only reason they called us is because everybody else that's been able to interact and keep things contained couldn't. And we get called in. But they're afraid. They're worried that we're going to arrest them, which many have been arrested, drug problems, drug addiction issues, or we're going to take them to an emergency room, which is going to cost them money they can't afford. So they do not reach out to us proactively, with rare exception. Those exceptions are when they're so worried that their loved one will be dead. That's when they call us. And then they're actually wanting us to lock them up to save their lives, and we can't do that either. So I felt that with all the good things everybody's doing, law enforcement needs to be a part of that. We are the responder on the street in crisis that initially deals with this. There's a lot of resources that come in behind to support it, but we are there first. So it got me thinking that what if law enforcement could be the good guys and gals that is actually offering the option to avoid jail, to avoid going to the ER, and have us say we want to help you. What could that mean to a community? And I started talking this 2.5 years ago. I started talking with Scott. I started talking with Brandon Hatch, Davis Behavioral Health, with local law enforcement officials, legislators. Everybody I talked to, what I was looking for is anybody anywhere in the country doing this, where law enforcement is diverting before a charge is filed. No citation, no charge. We couldn't find it anywhere. We talked to federal partners. They couldn't find it. Every program that I've seen requires some type of charge or citation, and then we do a whole bunch of things behind it to try to soften that blow. But here's the problem. We push them down a hole, and at the same time tell them, we want you to get better. We want you to rise above this, find the strength, the support, and to cure whatever ails you, which with mental health, I think it's a balancing act. We don't cure most of that. We rebalance people. Drug addiction is in many ways a balancing act too, until they hopefully are able to get cured. But we're pushing them down first. So we couldn't find anyone that was doing it the way that we've started this pilot. So that at least gives you a little bit of the background as to why I feel passionately that this is the biggest program that I've been involved in my 32-year career. Davis Receiving Center is a pilot project that started in December. We've been running about 3 months. Only 2 cities have been participating right now, not because there isn't a desire, but we knew that there's going to be capacity needs, resource issues, and what could not happen is if law enforcement pulls up to bring somebody in to get help, if they're being turned away, they'll quit bringing them. So we decided we would ease into this. So Bountiful and Layton started 3 months ago. We brought in 64 people to date for help. Here's how this works on the street. Police officer is talking to somebody, maybe it's a traffic stop, they find drugs, paraphernalia, maybe they're called there for some type of crisis intervention. It's a low-level misdemeanor. So if it's a misdemeanor that does not require restitution, does not involve violence, so domestic violence not included, assaults, does not include DUIs, but all of these other misdemeanors, the officer now has the ability to say, I'm going to offer you a program, a new program that we're doing, that will, if you go with me voluntarily, will stop me from moving forward with charges, as long as you are engaged in treatment. This isn't about relapsing. This isn't about, we don't know, but we don't believe it's even about committing crimes, although at some point that could be the issue. This is about trying to give people the best help up front, no negative impact, and get them started in a way that they've never had. Out of those 64 people, only 2 have walked away from the receiving center. That's phenomenal. 60%, a little over 60% are still in treatment 3 months later. That's phenomenal. The people I've talked to and that have called me, or their families, they cannot believe that the police officer, the person that they in the moment feared the most, standing there in a uniform, is actually the person, because they are connecting with them and helping them, that they want to connect with the most. Anyone else that cares the same as I do and others, and there's many, the fact that I'm wearing the uniform and I'm reaching out and saying, I want to help you, I can take you somewhere that can start you now, immediately in treatment. And we will support you through this process. That the outpouring has been incredible. We have parents that brought in bagels to Bountiful Police with a poster that said, "Thank you, Bountiful Police, for being a bright star in the dark skies of mental illness." The police department. I'm not doing anything different than people in this room and many, many others. But they don't expect it from us in crisis on the street. And it's a game changer. Not only is it changing the people that we're bringing in, many of which are emotional, from just the feeling that I thought I was going to jail today, but now I'm actually getting help and taken to get help by the very person I might have feared the most. Our officers are changing as well. Just a few weeks ago, I had an officer that responded on a mental health call, talked with this individual. He did not want to go to the receiving center. There was no crime involved. So at that point, it was an option. It didn't require us getting an evaluation. There's no pink sheet that's required. This officer and this individual texted and phone called 5 days after that. He came to our police station, to that officer on the 5th day, and she drove him to the receiving center. That's the difference. Instead of an officer viewing this as a criminal violation or something that is somebody else's problem, they actually accepted and agreed that we play a role in helping people get treatment. And not only does it change that individual, the family is changed. Can you believe or even imagine the day that a police cruiser pulls up or an officer walks through a door and is welcomed in people in this vulnerable population saying, "Thank goodness you're here, I need help." If we can delay a crisis mental health response by 2 weeks with the same individual that we respond on over and over, because they can contact us, they are not afraid of us, they can reach out, think of the economic savings alone. Let alone the fact that for this individual, that was the best way to start getting help. So, of those 64...
Will you have time for a question? I just wanted to know.
Yes.
After you're done? Okay.
I'll stay and talk. Couple things very quickly. 52% of those individuals would have gone to jail that day, had this not been an option. 28% would have gone to the emergency room by law enforcement. So 80% of those people right there, we cut out of the criminal justice system initially. Now here's the carrot. I talked about the carrot, here's the stick part. If you stay engaged in treatment or you're able to overcome your problem or addiction, we will never file those charges. The police department holds on to that report unless we are notified by the caregivers, Davis Behavioral Health, that Tom Ross has quit showing up for treatment, and they try to re-engage them up to 30 to 60 days. Then, if they haven't, we will file the charges. So there still is accountability. For those that say this is soft on crime, you're missing a couple key parts. One is, when we arrest somebody, take them to jail, they are out typically within 3 hours on misdemeanor offenses. They go to the receiving center, they're there at least 20 hours. Up to 72 hours, and we kept some up to 30 days. They are removed from the community. So that is public safety. That is, for anyone that thinks this is soft on public safety, it enhances it. And they go into an environment and gives them treatment. So the last thing I'll say to end this, because I know there's plenty to talk. I like music, I listen to music all the time, that kind of drives what I do. So for some weird reason, whatever, I've been listening to Van Halen, but the song Love Walks In, which they did not write about police officers. And they could have. Yeah, they should have, because this is it. It talks about something different. Something's changed. I sense a change. And an alien, well, I'm talking about love, but this alien, which is us, because to them, we're the worst thing that they can see that day. And then love walks in. So we come in, we offer help that they have not ever seen before. And they're impacted. I think it's a game changer. And I'd be happy to answer any questions.
Thank you so much for that presentation. That was great. So I think you said the program's been up 3 months?
3 months.
And so you said you served about 62 people, so that's 2/3 of a person per day on just averaging it out. With the staff that you have there, what capacity could you serve if there was a higher capacity?
So I appreciate that question. We just opened it up to 5 more cities yesterday. So over the next 2 or 3 weeks, Clearfield, Farmington, West Point, Fruit Heights, and South Weaver, they will come in. We have 42 beds. We know now from 3 months that we can handle more capacity than we've been doing. This has only been Layton and Bountiful participating. My hope and belief, and those in our group feel that after this next segment, in about hopefully a few months, we will open it to the rest of Davis County. So the desire is to have all Davis County communities participating. I've had chiefs calling me from communities that aren't saying, Tom, you got to get us in, because we're getting calls from our residents saying, why aren't we doing this? And we just wanted to make sure we didn't the resource capacity issues are real. But they also have been able to get people into long-term treatment. 40% of the individuals, Davis Behavioral has been able to get into long-term treatment. That's been incredible. Now, we don't know when everybody, if we have hundreds someday, but I'll still say this, the start of it is worth trying this. And I believe the end result will be better, but even if it's not, if people still reoffend in crime, they still have drug problem or issues at the same rate, I think that will change. But if they don't, the way they're starting in this changes how everybody views us.
Hey Chief, I know we said one question, but I know some of the legislators are going to be watching this after the session, and they're going to the question is going to be, can this be done in any jurisdiction, and how do we start doing it? And I know that's a long answer, but could you give us maybe a short answer to those questions?
The short answer is yes. I believe that what is happening in Davis County could happen everywhere in the country, to the most part. I believe it could. The one piece that I think most fail to put enough effort in the process is building the coalition and the collaboration. If someone just jumps out and says we're doing this, and they don't have law enforcement educated and working on this, and they don't have the service providers, I think that's the problem that fails. But yes, we can do this. We just need to look at it differently.
So how long did it take you from the time you decided you wanted to do it until you were able to open it, and how many millions of dollars did it take to be able to open the facility?
2.5 years we started talking, and you weren't here at the beginning, but I referenced that you were part of the conversations, and a big part of it. The funding we received last year, half of it, it's $1 million total, half of it Davis Behavioral Health put up, half of it was put up through some grant funding that came through Doug Thomas's office, Utah Substance Abuse and Mental Health, and they've been fantastic. We've been able, the sheriff, we have a new sheriff who is phenomenal. Kelly Sparks, if you haven't met him. This takes everybody. They have given us a portion of their work center in the building, in their jail complex. They are supporting this with laundry and food resources DVH is paying for. Representative Elison's bill now that he is running on receiving centers, I believe about $2.5 million of that would go towards Davis County to continue this pilot and move it to a more permanent location. This is a temporary. But I do think that this has the potential to save money within a county, which is the bigger problem we're having now, is for the state to try to provide money to a county that's hard. But if the county can save money on the corrections side and shift some of that in the treatment side and have the sheriff be a part of that and the commissioners, I think there's a future for this.
Now that you've done it to a certain degree, if another county wanted to do it, how long do you think it would take for them to copy what you've been able to put together? Do you think it'd take them 2.5 years to be able to pull it together?
No, I don't, because a lot of it's having something to look at. I just hope that they spend the time to collaborate and get people on board. We have not had a single chief or sheriff. It didn't start this way, but as we've rolled it out, nobody has said, can't do that, can't do that. We're going to let the pilot tell us what we can't do. We don't know how many times you can reoffend. We're probably going to figure it out. And there will probably be a time where we say, Tom, you've been here 6 times. You're going to go to jail and stay in jail, and sorry. But we're not even saying that today. I think the pilot needs to play out. The state of Utah needs these pilots and anyone else doing it to answer these questions, in my opinion.
Thanks, Chief.
Appreciate it.
I don't suppose you can tell that Chief Ross is genuinely excited about this. And I don't blame him. It is a game changer, and we believe that firmly. It will change the way we do business, and especially in our community. I want to transition now to another kind of game changer, and that is the work that's being done every day to save lives and to put people in a position to recover, because recovery is what it's all about. We want to get people connected. We want individuals, families, and communities to reconnect so the recovery can begin. So we have Dr. Jennifer Plump from Utah Naloxone. And she's whispering something to me.
Yes.
Something very important.
As I was having the IT people help me, I was like, oh geez, I hope the IT people can make the
Geez.
Yeah,
Okay.
yeah.
That's good then.
That was the whispering was.
Oh geez, I don't know any jokes, so I can't help you out there. Yeah. So, Ned's going to talk about Utah Naloxone. Then we'll go to the next part of the program. We have folks from the Department of Health. We talk about the opioid task force that Charlie mentioned at the outset. And then finally, we have Utah Support Advocates for Recovery Awareness, USARA. I got that right for the first time. And Evan Doan is here for them, and they will continue with the program.
Sorry, Jen, I thought you were
As
going
soon as we have IT, we're on our way.
Well, and maybe I don't need slides. I don't know. I'm just so used to being a visual type. While they're yeah, well, I was just gonna say while they're doing that, where did Chief Ross go? There he is. So unless it sounds like what they're doing is a lot of hype and a lot of law enforcement just saying, "Yay, look at us, this is great." I can tell you from someone who works with the folks who are out there struggling and the families who feel like there aren't options and people trying to build programs that make a difference. This is remarkable. This is truly what we need more of. And I went up to equip all of the folks at the Davis Receiving Center with naloxone, and they're now equipping anyone who comes in and out, no matter how long or short they're there. And it is the real deal. So you got something to be pretty proud of. You really do. Yeah. I rarely only talk 10 minutes. Anna's probably going to smirk at that thought because there's so much surrounding this issue. But I thought if given a quick 10 minutes to talk to y'all, what would I want you to know? I figured what I could do would be to teach people who have heard naloxone before, know in theory what it does, how to actually use it, and to teach you, what it is, the simplicities of it, and then you can think about realms in your world where folks would benefit from a similar type learning session. We are not having IT friendliness, so I'll just tell you, naloxone, heard it a lot, Narcan. Narcan means narcotic antagonist, or stands for that. Naloxone is just Narcan. It has one job. You can't get high with it, you can't relieve pain with it, you can't overdose on it, you can't become dependent or addicted to it. The only thing you can do is reverse an overdose with it. You know those memes that you had one slide, you had one job memes? My son is somewhere cringing because he told me I can't say memes anymore because I thought it was Mimi. Yeah, sorry, Max. Anyway, it has the one job, and the only thing you can do with it is reverse an overdose. It's not new, it's been around since 1971. It does not have any side effects on anyone if you give them naloxone and they're experiencing something other than an opiate overdose. That is where the win is in this stuff. So when Utah got itself to be fourth in the nation, a really, I think for a lot of us, unbelievable place to be for overdose deaths, because we're a state that has lower substance use rates, lower alcohol rates, lower tobacco use rates, and we still ended up here. Yeah, go
I
ahead.
think the microphone might be wireless, Jen.
If you want to go on, if I want to go on walkabout?
If you, yeah, want to be mobile.
I feel a little like I'm on The Voice.
If you want to walk up,
I feel a little like I'm on The Voice now. Anyway, we found ourselves fourth in the nation, and luckily there were legislative efforts and Department of Health and Public Health in general efforts. How can we get better? Because there is a lot of work to be done, and it is not something that can be done overnight. The crucial start was, how do we keep people not dead? How do we have people not have a chance to get to those next steps, where there will be more programs like the Davis Receiving Center, where there will be better access to medication-assisted treatment. So naloxone was a perfect answer. We were lucky enough to have legislators here who passed really good naloxone laws in 2014. I feel naked without my slides. I'm used to being able to show you with a slide. But I'll tell you, the 2014 laws, what they essentially did was said, any human in the state of Utah can have naloxone, can have it. Could be someone who's at increased risk of overdose. It could be someone who's at increased risk of witnessing overdose, which, let's be honest, this days is anyone, right? Whether it's your family, your friends, somewhere you work, it's possible for any one of us to see an overdose. The law also said the only legal requirement for me as a physician or a pharmacist to give someone a kit was to make sure to tell them, you call 911. This was not about going rogue. This was not about taking it outside of the system. This was about equipping people to save lives. We went back in 2016 to go a step further to make it so that you didn't even have to be a physician or a pharmacist to equip people with naloxone. Any individual, this is literally what's in the law, individual, can furnish a naloxone kit to anyone else in this state. Oh. You snake?
Well, you might be able to connect now on yours.
Push that button and see if I can.
Let's see. Sorry, everyone.
Anyway, we'll keep going. I mean, there's pretty pictures, but I'll just keep making sense with it, hopefully. 2016 law said any individual can equip another individual with naloxone, and this was a change, right? It's already a little bit strange that I can give you naloxone to go use on somebody else. I can give you naloxone to go use on somebody else, because that's not the way pharmacy laws are written. I don't know if you guys have heard there's a bit of a syphilis outbreak that's been going on in Utah on and off for the last bit. The way that we treat syphilis is with penicillin. I bring all kinds of good news, by the way. But the way that we treat syphilis is with penicillin. I can't give you all 24 bottles of penicillin and say, I want you to treat yourself, 5 of your family members, and 18 of your neighbors. But the way the naloxone laws are written, I can absolutely say, I want you to have 24 kits, you have it, 5 of your family members, and 18 of your neighbors, and it's absolutely legal for every one of you to have it. In Utah, in a culture that is sometimes not comfortable talking about things that are potentially judgment or stigma drawing, the way we save lives is to equip people with naloxone hand to hand. And sometimes that does mean a physician, and sometimes that does mean a pharmacist, and sometimes that does mean a health department, and sometimes that does mean a medical clinic. But sometimes that means a syringe exchange where people who use drugs come to get fresh syringes and get tested for Hep C and get tested for HIV. Sometimes that means it's a recovery setting where the USARA Arches program goes to the University of Utah when people are experiencing that crisis moment and want to start medication-assisted treatment, and they make sure they're equipped. Sometimes it is law enforcement and EMS who knows who's at risk and give someone a kit. No names, no questions. Only legal thing they have to tell them is call 911 if you use this. Sometimes it's a mom. There's a mom in Utah County, Lana, has 8 children. 4 of them are heroin addicts. She has saved 13 lives that I know of by equipping other parents who would not talk to their docs, would not talk to their pharmacists, would not talk to their clergy, would not talk to anyone official, but they would talk to each other because they felt they got each other, right? There's a gentleman, I could keep going with stories, but this is up in Ogden, who he's one of my favorite humans I've worked with along this whole process. I hear from him, I'll call him Jay, I hear from him periodically, and he is in and out of incarceration, and he's in and out of situations. And when I first met him, he was in active drug use, and he wanted kits to help save his friends. And he wanted his mom to have a kit to help save him if he would need it. And those kits were used multiple times. This is back in 2015. And I didn't hear from him for a while, but I heard from his mom, and he had gotten incarcerated, and he'd had some legal system entanglements, but she wanted to make sure his friends were still covered. I heard from him when he got back out, and he was hopeful he would stay on that sobriety path, but he wasn't. And he knew that if he started to use again, that was when he was absolutely at the most risk of dying, and he wanted to make sure that until he was in that place he could stay sober, he wouldn't die. Went back into incarceration, came back out. I get all kinds of texts from him. And the most recent time out, he said to me, he called, and he actually wanted to set up a meeting because he had a plan. Not only did he want to equip his friends and his mom now, but he wanted to equip all of the PO officers that he was working with. He wanted to equip the people at the homeless shelter where he knew folks were around. He wanted to start having his own kind of outreach. I've watched this person as he's gone from someone who just was deathly afraid of dying or losing someone he cared about to someone who now cares about his community. I am willing to bet that Jay has saved more people than anyone I know. And I'm an emergency department physician. I know people who've saved a lot of lives, right? I have no doubt that this gentleman is responsible for dozens and dozens of people being saved. So for me, naloxone means you give people the power to not die, but you also give people the power to help others not die, which ultimately brings us all into this, what does it mean to be better? And to me, that means somebody's getting better. Anyone ever seen an opiate overdose before? Yeah, you won't forget it once you've seen it. The things I want you to know quickly, because I have naloxone kits here and I want everyone to take one, and I'm going to make everyone take one because then it's like nobody feels like they're self-identifying because they took one. If you see someone who's down and you're worried it could be an overdose, these are the 5 things I want you to remember. They're not talking, they're not moving. Starters. This is not someone who's nodded out and slurred. That person is dosed or high, and they could be on their way to an overdose, so you got to watch them carefully. Overdosed is out. Not talking, not moving are the first 2 things. And then I want you to look at their eyes, their lips, and their lungs. Not talking, not moving. Eyes, lips, lungs. Their eyes, and I have wonderful pictures that you're not being allowed to see, that their eyes get something called a pinpoint pupil. Tiny fleck of pepper pupil. You pry an eye open on someone who's down and it's like a little fleck of pepper in their eye, you've got an opiate overdose, period. But say it's a dark room or dark eyes and you don't know, you can't tell, you're not sure, look at their lips. When you overdose on an opiate, you're not breathing. They're going to get bluish, grayish because they don't have oxygen. You can look on the inside of the lip, you can look at the fingernails if you're not feeling like you can tell in their face. And then look at their lungs. Again, when you overdose on an opiate, you're not breathing. You're not going to see a lot of this. Sometimes you'll hear this awful, super attractive, right? You're going to remember it though. This awful kind of guttural breathing. Whoa, nope, it's still you.
Getting there.
We'll get to the end, I'll show you a couple pretty pictures and we'll be done. Not talking, not moving, eyes, lips, lungs. That's what you're looking for. Don't feel like you have to go full nurse. Don't feel like you have to count out how many respirations they had. Don't even feel like you have to figure out if, where, when the pulse is. You think someone's having an opiate overdose, you call 911. You put it on speakerphone. You get your naloxone kit. If you're lucky to have someone else there, you have them rescue breathing for them while you're getting naloxone ready. And you give them naloxone. If it turns out that it's not an opiate overdose and you gave them naloxone, you will not hurt them. If it was a stroke, if it was a head injury, if it was diabetes, if it was a heart attack situation, you don't know, right? They're just down. You don't know. If it's an opiate overdose, you just saved their life. If it's not, you did not hurt them, period. And in these days when we're seeing more fentanyl, which acts much more quickly than other opiates, time is so of the essence. Minutes literally can make the difference between whether someone gets to wake up or not. The kits that we have, there are intranasal kits that are out in the community. Those are an option if you want a prescription called in. Some pharmacies you don't even need a prescription for. Some people don't like needles. These are an option. They're about $150 cash price. The kits that I have for you here today are all labeled like any prescription would be. They have the physician name, happens to be mine, on it. You can put your name on it if you want. You can give it to somebody else to put their name on it. You don't have to have a name on it. It is not paraphernalia. The AG's office, the DA's, we've had just about everyone that can possibly say it is not paraphernalia. Do not worry about having it. Each little vial, it doesn't look so good in the blue. This single vial is the same dose for everybody. 6-month-old kids, 6-year-old German Shepherd, 16-year-old girl, 60-year-old dude. Doesn't matter if they're obese or tiny, doesn't matter if they're pregnant, doesn't matter if they have liver disease, heart disease, kidney disease, does not matter. This is it. This is part of the reason we can do this so broadly. You're not going to hurt somebody with it, and it's always going to be the same dose. Always going to be the same response. There's a little orange cap you flip off. Now, people who worry about, oh, you're giving people needles? Look at the size of that thing. That's a dagger. That's not something people use to inject drugs. That is a big dagger of a needle that we use to save lives with, period. You go right through the top of this. Look, again, these are not, you don't have to be gentle. And there's videos on our website, but if we're doing something in a bigger, longer term setting, I can have people walk through it one at a time. You move your needle right down to where the liquid is. Oh, geez, I pulled it out. That's all right. Just go right back in. All that liquid, you pull it all the way up. You do not worry about if there's bubbles, and you do not think you're in Pulp Fiction. If the only thing you remember from me today is I will never stab someone in the heart in my life, we have won. No, do not stab people in the heart. Arm, thigh, butt, big muscle. And you don't have to throw darts. This stuff's going to go in like butter. Just right, boom, just like that, and push the med in. It's as simple as that. If you get that to someone in time, you will save their life. I can tell you in the 5 years, nearly 5 years that Utah Naloxone's been in existence, we've gotten out about 70,000 kits, which is 140,000 free doses of naloxone. There are 3,661 times people have told us they saved a life. These are not medical people. There are 362 law enforcement officers who have saved a life, and I will absolutely agree with what Chief Ross is saying. There is a change in the way of thinking when people start to look at folks as, wow, how can I help them, instead of how is this just for us as a society. 18 Salt Lake County libraries all have free kits for people. I would love libraries across the state to be willing to do the same thing. Not have much luck anywhere but in Salt Lake, but if anyone knows folks in other counties, I would love that. People love their librarians and trust their librarians more than they trust their docs and their pharmacists and their health departments in some situations, many situations. The goal for me, like I said, give people a way to keep folks alive while the system is getting better than it has been in the past, and naloxone has been a tremendous way to do that. So get ready. I'm going to start passing kits down the rows. Does anyone have any questions about naloxone? Does anyone have a question about how to use it? Anyone have a question? Am I going to have to make you all say the 5 signs? Not talking, not moving. Eyes, lips, lungs. 100%, do you have to see all of those things? No. The one thing it does have to be, not talking, not moving. This is not somebody running from you saying, hey man, don't give me that naloxone stuff. This is somebody that's down, that you really are worried about. So grateful to be able to be amongst you all, and I'm going to eat 14 more servings of pasta and pass out kits, and I will one day figure this out.
Once again, any questions for Dr. Plum? We'll have our friends from health come, hopefully.
Scott, she said she had kits?
Yeah, I have kits.
You have kits?
Yep, I'm going to be passing them down the rows.
Okay.
They, like I said, they are the injectable kits. There's some thinking out there that the intranasal are better. Well, the best form of naloxone to have is the best form of naloxone we have. And I'm a big believer in the medical gold standard, which is the injectable, and I'm also a big believer in cheap. If it's the cheapest and it's the medical gold standard, that's the way I go. So, they'll be coming down your eyes.
Yeah.
All right, thanks, Doc. Once again, tremendous work that they've done, the lives that they've saved across the state. It's just unfathomable. We're so lucky to have that kind of support and dedication in our community. Meanwhile, back at the ranch, we have folks at our State Department of Health that are working on all kinds of innovations technologically. Today we have Anna Fondario, who's the director of the, I always get it wrong,
Violence and Injury Prevention.
Violence and Injury Prevention Division of their health, along with Megan Ballou, and I always get that wrong too.
Balo, close.
Balo, so I'm wrong twice. And they're going to show us a little bit about what's going on in the tech world in their department with regard to data coming out on opioids, and constant streaming factors. So, turn time over to Anna. Thank you.
Hi, everyone. Thank you for being here. While they are getting connected, because what we really want to show is the public opioid dashboard that we developed, and then we'll talk a little bit more about an internal dashboard that we're developing. I just want to go through a couple of interventions that the Department of Health has been working on. Again, my name is Anna Fondario. As Scott mentioned, I'm the program manager for the Violence and Injury Prevention Program at the Department of Health. We recently received federal funding to address the opioid epidemic in our state. It's called the Overdose Data to Action Grant, and we fund a variety of programs within the health department. This grant is really focused on using data that we have primarily at the health department to inform the prevention programs that we have throughout the health department as well. So I'm just going to quickly go through a couple of these interventions. I'm going to start with academic detailing, and this is really peer-to-peer education of providers. We focused on dental providers and then also primary care physicians throughout the state. And what's really significant about this is that we looked at prescribing behaviors of these providers prior to taking this academic detailing session and their behaviors after. And we saw some changes in their prescribing behavior, particularly the number of opioid prescriptions they're dispensing, high-dose opioid prescriptions, and then prescribing, doing co-prescriptions of benzodiazepines and opioids. And so we're really excited about the changes in prescribing behavior that we've been seeing through this program. And we'll be presenting actually this data and results to the CDC at the end of the month.
We're on our way.
Okay, and so the other effort before we go into the database I want to talk about is our Opioid Fatality Review Committee. So we've been implementing this committee over the past 2 years, and we've looked at a variety of deaths related to opioids, and we've done a more in-depth review of these deaths. We meet at the medical examiner's office with a variety of key stakeholders, and we go through the different deaths. Some of the things that we've reviewed are deaths related to gabapentin. We looked at hotspots throughout the states and reviewed deaths where we've had some of these hotspots. We've also looked at deaths where they've been recently released either from treatment, from surgery, from law enforcement, and looked at individuals who died of an overdose death once they've been recently released. And each of these tests, maybe the battery is out.
You can't have a microphone and a...
Okay, I'll just speak really loud, really loudly. So those who died of an opioid overdose that have been recently released, we looked a little bit more closely as to what are some contributing factors and interventions and recommendations to kind of prevent those deaths. And then we're currently looking at veteran deaths, and then recently we looked at an opioid cluster that we identified earlier this year to see if there were any commonalities and risk factors that we could have prevented or gaps in services to help prevent these deaths. The other effort that I want to talk about is our Stop the Opidemic campaign. You may have seen a lot of our billboards, social media ads, digital ads. One thing I just want to highlight with this campaign is that we have a video. It's been out for a couple of years now, but they've tested this video nationally. It's related to naloxone. And out of all of the other videos that have come out for media campaigns throughout the nation, this has ranked the highest as far as effectiveness with the evaluation. And so it's really great because we're serving as a model nationally for this media campaign and this video. And it's basically showing an individual who's prepared to use naloxone and another individual who is not prepared to use naloxone and kind of the steps going through that. So we have some media efforts that we're working on. The other thing that the Department of Health is working on is supporting some of our efforts with neonatal abstinence syndrome. And so that's infants or babies that are born that are experiencing withdrawal symptoms. So we are working with the Utah Birth Defect Network, also maternal and infant health, and implementing opioid safety bundles for women who are discharged from the hospital after delivery, and also looking at tracking and surveilling neonatal abstinence syndrome. And then I also want to mention that we have funded United Way 211 to serve as a substance use disorder helpline. And we have been promoting this so individuals, anyone can call United Way 211 and be able to get navigated to services. So we know that this is a very difficult time for family members, loved ones, individuals who are experiencing addiction and trying to navigate services that are available, knowing what insurance covers, if they need outpatient, inpatient treatment, etc. We have 211 that's helping with that navigation and providing some follow-up services. We also work with our syringe exchange programs and support some of their efforts to make sure that individuals who are accessing those services are being connected to care and being provided resources. In addition, working with them to make sure that we are not increasing infectious diseases like hepatitis and HIV. I won't talk very much about our naloxone efforts. Utah Naloxone does an amazing job at getting naloxone out to the community. We do have targeted naloxone distribution through the health department, and we do the intranasal kits, but we really focus on individuals who are at risk of overdosing or people who are interacting with individuals who are at risk of overdosing, so that we can make, because we don't have a lot of naloxone kits, so we have to make sure that what we do is a little more targeted in the communities. And then the other thing I want to mention is that we do support each of our local health departments. We've worked with them over the past couple of years to develop an opioid community crisis response plan, so that if we do have an outbreak of opioid overdoses in our communities, that we're ready to respond quickly. And within the Department of Health, we've also developed a substance use related emergency response plan that kind of guides our actions when we see an outbreak or a cluster. We want to make sure that we're prepared, so if we have 70 overdoses in a weekend, how are we going to quickly respond and mitigate some of the risks that are occurring, and what that looks like. We've practiced that earlier this year. We saw a little bit of a cluster, and we were able to practice our plan with some of the local health departments. And so we just want the public to know that we are prepared and ready to respond quickly so that we can prevent additional overdoses if needed. And then before we get into the database, we do support enhanced toxicology testing with our public health labs, and then we also are supporting efforts through the medical examiner's office so that we can identify suspected overdoses pretty quickly. When we have an overdose death, there's toxicology results that we have to wait for. This data has to go through the National Center for Healthcare Statistics to get a code back to designate it as an opioid overdose. So we have been working on a suspected drug overdose definition that we're working with the CDC on so that we can quickly identify these while we're waiting for that confirmation through NCHS or through toxicology. So with that being said, just some of the data that we have. The current state of Utah's epidemic, each week we're currently seeing 11 people die from drug overdoses in our state, 8 from opioid overdoses, and 4 from prescription, specifically opioid overdoses. We have started to see an increase in our illicit drug overdose deaths, which is concerning. It's something that we are tracking and keeping an eye on. But historically in Utah, majority of our deaths are from prescription opioids, but we want to make sure that we're keeping an eye on some of these novel emerging drugs that we're seeing, methamphetamine, and then also, of course, heroin, fentanyl, and some of those other illicit opioids that we're seeing. This is a trend line, and Meg is our opioid epidemiologist, so she is the expert really in our opioid data. And so jump in, but if you look at this trend line, there's a couple things that I want to point out. So 2019 is still preliminary, but we only have about 56 cases right now that are pending that will either become an opioid overdose or just maybe other cases. But this is pretty impressive if you look at our preliminary data right now, how much we have decreased from 2018 to 2019 in our deaths. This, of course, is still preliminary data. We're still waiting on toxicology and other things. But one of the things that I want to point out is that if you see here in 2000, you see this dip here between 2007 and 2010. Just a year or so before that is when we really started seeing these increases in opioid overdose deaths. A task force was developed. The medical examiner was involved. There was legislation to address this problem. A lot of our legislators were very proactive in passing great legislation, providing funding. And through all of these efforts, we saw this decrease. Starting in 2010, going up to about 2014, all of these efforts were siloed out, and it was very difficult to kind of be more collective in our approach with this. And you could see that we started seeing increases. There were other things that were occurring as well. And then since then, we've had state funding and some federal funding, and we've had so many community organizations and other agencies, state agencies, really take kind of ownership of this problem as well, and leadership roles in this problem. And so we're starting to really see the effects of this and decreases because of all of these efforts, collaborative efforts through the task force, through the coalition. So, you know, kudos to Dr. Plum, Chief Ross, USARA. I think all of these collective efforts are really, you know, we're really starting to see the benefits of that. Do you want to say anything else?
No, I think you handled it. We were kind of surprised. It's like it's quite a decrease, and we're following up with that to make sure that it's accurate. But when we did look at our pending list, there were only 56. So we may start to see that downward trend and keep it that way.
And hopefully, yes, maintain it. That's the key, is maintaining it. You know, we can fluctuate up and down, but the key is really maintaining efforts. And really not saying, okay, we're doing a great job and backing off. I think it's continual efforts that we need to be working on. These are just the specific numbers. You could see for 2019 compared to 2018 drug poisoning deaths, it was 621. We're at 413. If you look specifically at let's see, prescription opioid deaths without heroin, we're at 220. For 2019, we're at 154. Again, we still have some pending. At the health department, our goal is to get below 300 opioid deaths. So we're on our way there. Anything else you want to add? Next slide. And then this slide, we'll let you.
This one I just wanted to show just kind of the breakdown of what substances are present in deaths. So you have 2017 through 2019. You can see about 59% of those cases were deaths from prescription opioid, no heroin. That's come down 53% and 54% in 2018 and 2019. The others are pretty steady with their percentage of deaths. But I just wanted to draw your attention to, hopefully that continues to go down as we move forward.
So then we go to the Utah Public Opioid Dashboard. This is what the landing page looks like. There's the website for it. And our idea is that we'll start adding additional topic areas for this data. This is publicly available data, so it's not real time. And I'll talk a little bit about a separate dashboard that we have in development with real-time data in a second. But I don't know if we want to go to the live demo of this, or we'll just, okay, so when you click on that, we have some summary indicators of 2018 data. We're going to be working on updating this to 2019 information, but you could see opioid deaths, opioid prescriptions dispensed. This is from the Controlled Substance Database. Opioid-related ED visits, naloxone doses distributed in Utah in 2018, and then newborns with neonatal abstinence syndrome.
And these are static.
Yeah, so these are static.
They don't change, but she'll go into the next ones that can be manipulated to show certain areas and certain drugs as well.
So when you go down, you can look at trend indicators, and this will kind of just show you different things. Some of these indicators have that show detail, and when you click on that, you can break it down by local health district or county, age, sex, etc., to be able to look at that data a little bit differently. So we have deaths, and then we also have here ED visits where you can get into more detail, and then prescriptions dispensed that you could look at in more detail. And then again, as I mentioned, naloxone doses distributed and newborns with neonatal abstinence syndrome. And since Utah naloxone is here, we do include Utah naloxone numbers in the naloxone doses distributed in this data. So we'll be updating again this pretty quickly. The one thing that I just wanted to show, if we can go to the, oh no, we don't have that, huh? One of the things I was going to show, I don't know if we have that slide. Oh, maybe we can go to dashboard on it. So with prescription opioids dispensed, what I was going to show is that when you look at Utah prescriptions dispensed, you see a downward trend. But everyone has heard that Southeast, we have a huge higher rates of death in Southeast and higher opioid prescriptions that are dispensed in Southeast. And so when we can look at Southeast specifically, and though its trend line is much higher than what's being dispensed in Utah, you see significant decreases in opioids dispensed. So it's really cool to be able to see what's happening throughout Utah with some of these indicators. And I think this has been really helpful for a lot of our partners as they write grants or report on grants or report to their communities. They're able to look at their specific data. So while we're bringing that up really quickly, the one thing I wanted to mention, we are developing an internal dashboard. We're almost ready with it. We've done logins for all of the local health departments so that they can log in, and what they can see is almost real-time data of overdoses that are presented at emergency departments. They're able to look at emergency medical services data, so EMS that responds to an overdose, what if naloxone is disseminated, if they get transported to a hospital, and then our suspected drug overdose trend line. So they can look by the week or by the day how many overdoses, how many EMS responses, and how many deaths have occurred within their local health district. And this is to help us to make sure that we are keeping track of this data and responding as quickly as possible if we see anomalies in the data. We have a training with all of the local health departments in the next month. We've developed user guides, and each of the local health departments will be working with their communities to share this data and make sure they're ready for a response in the event that we do see an overdose cluster or spike. So this is the trend line I was talking about with Southeast Local Health District and Utah. And so it's great to be able to see our communities making progress in this effort. Okay, that's a lot of information. There's so much more detail. Happy to answer any questions or give me a call. We can go into a lot more detail if needed.
But if you ask for data, I'm just going to send you to the dashboard
Yeah.
first. It's going to free up my time a little bit, hopefully.
So thank you. Very good.
Thank you both for being here and just terrific stuff, and continue to evolve with the information that's available to us. We're all invested in the notion of real-time data. We think it's going to happen in our lifetimes, and it's so important to be able to make decisions based on what's really out there. So thank you again. We'll go to our last speaker, and I just want to say before I introduce Evan, I had the good fortune to be in the Rotunda last Thursday at the Rally for Recovery that USARA sponsors every year, and this event was stunning in terms of its impact personally on me, and also just the effect of having literally hundreds and hundreds of people show up in the Capitol Rotunda at 4:30 on a Thursday afternoon and celebrate recovery. And the message it gives to me initially is that we can all do better, and we can all help celebrate recovery by bringing it into the sunlight where it belongs. So much of what we've talked about during the opioid crisis has been related to stigma and shame and not being able to talk about it and not being able to have a meaningful conversation about addiction and about recovery and how we get there. And so USARA has been a pioneer for Utah and across the country, the Utah Support Advocates for Recovery Awareness. Evan is here on behalf of Evan Doan today. Mary Jo is going to be here. She had a situation come up at the last minute. So I just want each of us to kind of pledge to ourselves here today that we're going to do just one more thing to celebrate people who are in recovery and to support them and say, it's great, and we're with you, and once we reconnect you to the community, we can continue to support you after that. It's not a one and done, it's not a destination, it's a process. And so, Evan, I'll introduce from USARA and take it from there. Thank you so much.
All right, so my name's Evan Doan. I'm the Community Outreach and Empowerment Coordinator for the Utah Support Advocates for Recovery Awareness, or USARA. It's a mouthful. I'm also a person in long-term recovery myself. So, it's important to note that that's true of everyone that works for USARA. We're all people in recovery, so we get what it's like. We've been there ourselves. We have personal lived experience of living through a substance use disorder and coming out the other side. So we really exist to help other people find their way. So I want to talk a little bit today about what we do and kind of the role that we play in the community. So the kinds of services that we provide are called recovery support services. But just to back up for just a second, I want to talk just more generally about our organization. So we were founded in 2006. We're a 501c3 nonprofit organization. We're what's called a recovery community organization. So we provide non-clinical recovery support services. And that non-clinical piece is really important to note because we do not provide treatment services. We're not a substitute for treatment. So there are a lot of different treatment providers that are doing great work in this state. So if someone needs treatment, we direct them to those resources. But the role that we play is to kind of help people find their path either before, during, or after treatment services. And that said, we celebrate all pathways to recovery. So for many years in the United States, there was like one kind of predominant way of getting better, and that was Alcoholics Anonymous. And now there's lots of different ways that are available for people to get better. So there are things like fitness-based groups like Fit to Recover or Addict to Athlete. There are groups like Recovery Dharma, which is more Buddhist-inspired, or Life Ring, which is completely secular. So there's lots of different options for people to connect to sustain their recovery for the long term. So our mission as an organization is to connect and inspire communities to advocate for addiction recovery. And we do a few things. We say that we make a case for recovery. So we celebrate, advocate, support, and empower people in all stages of recovery from substance use disorders. And our vision for the state is that we envision a Utah where connection and recovery community are recognized as the most valuable asset for people to recover from a substance use disorder. So if there's one thing that you remember from my presentation today, please remember this. Recovery is not rare. Recovery is not random. People are recovering from substance use disorders all across our state, all the time. And given the right supports, anyone can recover. Like, I know that might be a little bit controversial, but I truly believe that anyone can get better if they've got the right supports in their lives. So if we can share this message of hope, I think that really helps people a great deal in terms of finding and sustaining their recovery journey. So a little bit about some of the kind of peer recovery support services that we offer. So we have 4 different recovery community centers across the state of Utah. We've got one in Salt Lake, one in Ogden, one in Price, so Carbon County, which has been hit particularly hard by the opioid epidemic, and then one in St. George. Through those different recovery community centers, we offer one-on-one peer recovery coaching. So, people are able to meet with a peer at a time of their choosing, up to once a week, totally free. And that's important to note as well about us. All of our services are completely free. We never charge anyone or ask for insurance information of any kind. It's super low barrier to entry. So we just want to make sure that people are getting the help that they need. We can often, in many cases, help find the resources to get them into treatment if they're looking for treatment. So we can get them enrolled in Medicaid or connect with a community provider that can provide those services. So I think that it's really cool that we can do that for the community and that people can just access us without any charge or insurance or anything like that. So we also operate a number of different kinds of mutual aid groups. I talked about that just a second ago when I was mentioning the different recovery paths. And we have, I think, pretty much all of those different kinds of recovery programs represented at our recovery community centers. So last year we had close to 2,000 mutual aid groups running throughout the state. We also have a program called the ARCHES program, and ARCHES stands for Addiction Recovery Coaching in Healthcare and Emergency Settings. We're a big fan of long acronyms. ARCHES is a team of peer recovery coaches that are on call, that are able to meet with people in acute care settings. So if someone goes to an emergency room in Salt Lake County, like at the U or IHC, the doctors or nurses will talk to them, and if they've showed up for a substance use related crisis and they say they want to talk to someone in recovery, we'll be there within an hour. So I think that's a really important point of connection as well, that we're able to meet with people in those kinds of crisis moments. So oftentimes these people are, they're suffering from just had an overdose, or they're in acute detox, and so we're able to show up and say, hey, I've been there, how can I help? And our goal is really to connect people to whatever the next stage in their journey is going to be. So we don't have any kinds of preconceived notions about what that has to look like. For some folks, it's giving them some naloxone and just providing some harm reduction tools. For other folks, it might be getting them into detoxification services or treatment services. So we're able to do that warm handoff and then also follow up with them afterwards to make sure that they got the help that they needed. So I think it's critically important that we continue to provide that service across the state and expand it where we can. Because what we were seeing was oftentimes people were going to emergency departments and were getting treated, and then we're not getting connected to the next stage in their care. So people were just kind of revolving around through the revolving door of the ER, coming in and out, and that's frustrating for everybody in the system of care. It's frustrating for the patient. It's frustrating for the healthcare providers. They suffer from compassion fatigue too. So that grant or that program is run through a grant that we get through the state through the SOR funding. And then finally, we have a number of different family support groups that we operate throughout the state. So right now we have 14 weekly groups in 11 different counties. And so those are run, like all of our programs, are run by people who are family members themselves for other family members. So these are families that have had a loved one struggle with a substance use disorder and have been able to kind of help them find their journey or find their path. And so we use what's called the CRAFT model. So Community Reinforcement and Family Training is the acronym for that. But it's really just one family supporting another. And I think that it's been profoundly powerful in helping those families in some of the worst moments of their lives when they're having a loved one who's struggling. I think that many of us in the room can identify with that feeling of feeling helpless over someone else's actions. And we teach them some tools that can help kind of influence what the direction that person might take would be. So recovery support services, we come in, like I said earlier, before, during, after treatment, formal treatment services. So we kind of really enter into someone's life at any point they need some additional support in finding their way. This slide talks a little bit about some of the outcomes of recovery support services, so increasing recovery engagement, reducing incidences of use, helping people to identify a pathway of recovery that's got meaning and purpose for them in their lives, overcoming common challenges. So, oftentimes people are struggling with housing insecurity or food insecurity or transportation needs or employment, and so we can help with all of those different kinds of things. And so really we come in to kind of bridge a gap between formal clinical services and a life in recovery, because many people will go through treatment, and oftentimes it happens more than once. But after treatment, what does someone do to sustain their recovery for the long term? And so that's what we're trying to provide, is that continued support throughout the course of people's lives so that they can manage what is really a chronic health condition. And then finally, we always want to empower and celebrate individual personal successes and achievements. So like I mentioned earlier, hope is super important. And so the more that we can show that people do recover and celebrate people's recovery, I think is critically important in fighting the opioid epidemic. So you can find out more about us on our website or our Facebook page, and that's about all I've got. Questions for me? Cool.
Thank you, Evan. And again, if you do have any, they're so receptive. Sarah and Mary Jo and everybody that's associated with that organization is so receptive to contact. I had a situation in my family that happened here just last fall. Another one of those personal stories. And I'll tell you what, when there's nobody else that you can think of to call, you can call Sarah, and they will give you what you were looking for. I apologize. I didn't see that abrupt ending coming. So since it's just us kids now, and Cameron, thank you very much, and Carter, for your support for this event, and thank you all for coming out. Ryan, thank you, and Chelsea, welcome to Utah. And let me just share with you the task force vision for Utah, because I think our success is going to be measured by really a simple formula where we have a seamless continuum of care in our state, starting with law enforcement, first responders, crisis intervention, emergency room folk, intervention folk, treatment, and then recovery that's available constantly and across the continuum. And when we see people recover and they're in long-term recovery, we see those people who have had a hand up turn around and extend their hand to the next person, and that's how we succeed. So, Sean, do you want to wrap or take shape?
Thanks. Thank you to all who attended, especially those who participated. Our presentations, I think, are compelling. We'll probably have to work on, when we take this and roll this out to counties and cities around the state, we'll tighten things up a little bit and we'll figure it out. But I hope you feel the passion and the commitment that we have from everybody here together. Legislators, thank you for an awesome session. By the time you're going to be watching this, hopefully everybody will have received what they wanted, and you will have been written up in all the newspapers for your tremendous work and not criticized a single bit. But this is an issue that, as I said before, we feel is a clear and present danger. It has been for a long time and hasn't quite received the attention that it deserves. That's changing. Utah's helping to change it. You and the legislature are helping to change it. And if you will help us open the doors to make sure that people in rural counties, that constituents that you have in urban areas who may not normally have access to these types of resources, that you can get them to these meetings that we'll have, these town halls, these showcases, because I think once they see a Jen Plum or a Tom Ross or Mary Jo or Anna and their teams, what they're doing, and Banjo, I think, will be part of some of the programs. We have other presenters that aren't here today that also have really cutting-edge solutions. So that's what I want to end on. We think that as a community, we've helped nurture and incubate a lot of solutions, and that's what we want to bring out to your communities. We'll focus on how do we emerge from this this difficult crisis that we find ourselves in. So thank you, Scott Reed, for putting this together, and Sierra Gregovich for helping to run our opioid task force. If you're watching this, Brian Besser in Washington, D.C., say hi to Udom there. We still love you, even though you left us and abandoned us here in Utah. And thanks one last time to the League, cities and towns, to UAC for being such great partners. I hope you'll take this back, Cameron, whether it's the video or just some of these ideas, and immediately start to spread word out that we're coming to a community near you. Anybody else? Anything final? Thanks. Appreciate it.